but to do three and to understand where it is really useful for a diagnosis. So I think this is a new and very interesting field also, B.
Hello, everybody. My name is Margarita. I'm a gynae and obstetrics doctor and a fetal medicine specialist, also part of FIVAP team. First of all, I would like to thank Professor Palumbo for the invitation to this course. For me, it's a real pleasure to be here. This is the last lecture of the weekend after very interesting talks and simulation training, so you must be really tired by now. I promise this will be a very easy and visual presentation, and I hope you will enjoy. There is no financial disclosure, and at the conclusion of this presentation, all of you should be able to understand how useful is 3D and 4D ultrasound in prenatal medicine, the impact of three-dimensional ultrasound in the detection of fetal abnormality, clinical recommendations for 3D and 4D usages, and how to use different settings and displays. I must confess that I'm not familiar with reproductive medicine at all, but I do have many patients that have conceived their pregnancies by assisted reproductive techniques. And as you know, many of them have been through a long and tough process with diagnoses they didn't expect, surgeries, many blood tests, failure of previous techniques, miscarriages, and it's crazy, but usually by the end of the treatment, the patients become real experts in hormones, gynecology, embryology. They can manage different types of medication at the same time. And finally, this is happening. And from this moment, the only thing that they want is this. They come to me with all their history behind, and now all they expect is this kind of scans. They ask for their scans in 3D, 4D, 5D, or all the Ds. And to be honest, I enjoy so much being part of Good News. I love these scans as much as they do, but what I know and they usually don't is that sometimes this is also happening. Sometimes during a 3D scan, we can find an increased nuchal translucency. We can diagnose a trap sequence in a monochorionic twin pregnancy. We can see cleft lips. We can diagnose an omphalocele, polydactyly, and also twin pregnancies in a horn of a bicornuate uterus. So here comes the key question. Is the ultrasound just useful to show beautiful babies' faces, or it can also be a diagnostic tool in fetal medicine? So three-dimensional ultrasound is available since 1980s. The first 3D image obtained in a pregnant patient was performed by Kazunori Baba, professor of biomedical engineering in the University of Tokyo. However, it was only after the development of most recent technologies and ultrasound system that 3D ultrasound reached the level of sensitivity and performance required to be seriously considered in clinical practice. It helps to overcome some of the key limitations related to 2D imaging, and it has been shown to be problem-solving tool in selected circumstances. Obtaining sonographic volumes rather than single tomographic slides allows to demonstrate data in any plane and in any direction, and this ability has enormous potential for medical ultrasound diagnosis. However, it's not yet widely used on a routine basis in prenatal medicine, and the role of 3D ultrasound is still being evaluated in many areas. We can storage not only images but also volumes that can be reloaded and reanalyzed at any time. And the availability of several displayed modes allows the demonstration both the normal and abnormal fetal anatomy. When counseling the parents, the rendered images can help them understand the severity of an existing malformation, or on the contrary, ensure them of the absence of fetal abnormalities. And of course, depending on the suspected fetal malformation, the operator has to choose the display mode that is best suited for the demonstration of the region of interest. A few technical aspects of the 3D and 4D ultrasound. Every 3D and 4D ultrasound procedure basically consists on 4 essential steps, and we're going to talk a little bit about them. First of all, the volume acquisition. Then we have to get the volume display, volume manipulation, and finally the storage of volume, images, and sequences. So when it comes to volume acquisition, there are two different systems available. Freehand system, this requires a sensor to be attached to the 2D probe. The advantage of this technology is that it can be used with any commercially available probe on a scan machine. And then the other one is the automatic system that needs a special 3D 4D probe that can only be used as part of a specific ultrasound system. Of course, it increases the cost of the machine, but on the other hand, they offer two major advantages. The image quality is significantly better and then can provide the operator with 4D ultrasound. As part of automatic system, there is newer technology known as matrix probe that contains a large number of crystals and it is electronically driven. It allows scanning in two planes simultaneously and it permits actual real-time visualization with a very rapid sweep, 1 to 2 seconds. After the acquisition of the image, we need to determine the volume display that we want to use for the area that we want to evaluate. Here we have the multiplanar mode that shows the 3 conventional scan planes. And by rotation and translation movement, any arbitrary plane of the fetus can be visualized in the multiplanar display mode. In particular, it enables the correct presentation of the median plane of the embryo or fetus that in the first trimester is important for the correct demonstration of the measurement of the nuchal translucency, nasal bone, or face anomalies like proboscis or retrognathia. This tomographic mode, the TWI, also known as parallel or tomographic display, enables detailed tomographic images of the fetus in sagittal, coronal, and transverse slices at different distances. So the region of interest can be displayed comparable to CT or MRI. We have also the surface mode. The surface mode provides the examiner with 3D images of fetal surfaces. A requirement is the presence of an adequate fluid pocket in front of the structure being imaged and the absence of overlying structures such as placenta, fetal limbs, or the umbilical cord. It's good that it shows the outer surfaces, but also can show the inner organ surfaces. We have here the HD Live Silhouette mode. This is a display that allows to check not only the surface of the baby, but also the inner structures as a transparent mode. We have also this Omni view. It allows the visualization of a specific sectional plane by drawing a reference line, a polyline, or a curve, choosing a slice thickness from 1 to 20 millimeters. It has great potential in prenatal diagnosis because it scans planes that are not achievable or accessible with conventional B-mode scanning. Here, for example, we have the profile of a fetus that we suspect here cleft on the palate, a defect on the palate, and if we don't do this curve here inside baby's mouth, we wouldn't have been able to get this picture of the defect in the palate. We have also this transparent mode, the skeleton mode. It provides a view of the fetal skeleton and the normal or abnormal ossification. We can use 2 different rendering algorithms. The maximum mode that displays only the maximum gray levels of the region of interest, so it will show only bones, and also the X-ray mode that presents all gray scale levels, so we can see not only bones but also the skin and the soft tissue of the baby. The minimum and inversion mode. In the minimum mode is this one here. Only the gray scale is displayed. So if there is a cyst or anechoic area, it won't be shown on the 3D plane. And this is very useful that it can be applied for a demonstration of vessels, hollow structures, or cystic structures. This is polycystic kidney. And the inversion mode is the contrary. It converts anechoic structures into hyperechogenic structures. So the inversion mode can be used to show the hypoechogenic portions in the malformation shown with the minimum mode as solid structure. So if we have here this polycystic kidney in minimum mode, we can take those cysts, convert it in inversion mode, and make them as solid structures. This volume display can be also performed with color render modes. Here we have glass body and pure color render mode. In the glass body render mode, it combines color and gray values. However, if we want to isolate just the vessels, we can just display the pure color render mode, and it shows only the color information of the color Doppler signal. There is also surface mode in 4D display, and it is a fast acquisition of up to 35 volumes per second. Both the surface and the movements of the fetus can be demonstrated continuously on the screen, and this enables the operator and the parents to observe the movements of the fetus, such as yawning, sucking, swallowing, mimicking, and body and leg movements. Other volume displaying for these 4D techniques is spatiotemporal image correlation, that is known as stick mode, and it provides the operator with a reconstructed cycle of the beating heart. And there is also a possibility of combining a stick with color Doppler as well with a detailed view of the cardiac blood flow. So once a volume has been taken and stored, it can be manipulated in different ways. Here we have the planar reformatting. Here we can rotate or translate the image to get a picture in any plane. When it comes to the electronic scalpel, sometimes when using surface rendering view, the region of interest may be covered by adjacent or overlapping structures, and these structures have to be removed with an electronic scalpel to obtain a high quality surface image. So here we have the baby with the hand and the arm in front of the face. If we draw a line over here with electronic scalpel, we can remove this part and get the profile of the fetus. The filtering. In some cases, amniotic fluid shows low-level echoes that disturb surface rendering and should therefore filter out by increasing the threshold value. So we remove here the echoes of the amniotic fluid and we get that image. And of course, we can do a 3D image post-processing. We can modify brightness, contrast, or colors to get the best view of the face. Also, we can do measurements. After reloading a stored volume, measurements can be made in any arbitrary plane. That's the corpus callosum, the measurement of the corpus callosum. And the 3D scene display, that image animation, it provides images at different angles so the physician and the patient can see the object of interest rotating on a screen and obtain a better spatial impression. For this scene sequence, so if we have taken for the video, for the clip, we can also manipulate it after reloading. So for this scene loop allows the examiner to display the scene sequence once again at different speeds and to scroll back through several volumes to choose a particular one. So here we play the video, and then here we can stop and scroll back And then we can choose the clips that we want to show the parents, or if we want to make it shorter and save pictures from the video. All those things can be processing after taking the volume. And finally, the storage. Once stored digitally on the hard disk of the ultrasound unit, the operator can retrieve the volumes at any time and navigate through this in the absence of the patient. So after the patient leave the room, we can then take the volumes, start playing with them, choosing filters, modifying, and the volumes can be stored on an external hard disk or DVDs for long-term usage. Now that you know the different display modes, I'm going to show you a few examples of the different fetal achievable anatomical structures. All the fetal structures that we can check or we can review with 3D and 4D ultrasound. Here we have an example of the skull and the cranial sutures. The assessment of baby's faces, not only to show this beautiful face to the parents, but also to demonstrate effects on fetal face with this surface mode. Here we have the central nervous system using different displays. It's the 2-in-1 multiplanar render mode, and here the surface that we can, in the surface mode, we can, as I said before, we can not only see the external body of the baby, but also the surface of the inner organs. Here we have an example of images of thorax and ribs. Here we have with the transparent mode, the skeleton mode, we can see the ribs, the thorax. If we go into the baby in this surface mode, we can see also the lung and the liver. In this patient, there was a pleural effusion here, so we can see that there is no virtual space anymore. It's completely filled of fluid here. And then we have here the multiplanar example of a congenital diaphragmatic hernia. This is the sagittal view. We can see the stomach inside the thorax of the fetus. Here in the axial plane, we can see the heart and the stomach inside the thorax. And the coronal view, and this is the 3D rendered mode. In surface mode, we can see the heart and the stomach inside the thorax. When it comes to the abdominal wall, we can also demonstrate defects. This is a 2D scan of a baby with a gastroschisis, and this is the same patient. When we do a 3D scan, we can see the bowel outside the abdomen of the baby. Of course, this is not found by chance. For you to get a good 3D picture, you need to do a good 2D scan. It's unlikely that you are scanning a baby, you do a 3D, and suddenly a gastroschisis appears. First of all, you need to suspect it, and then do a 3D scan to demonstrate the malformation also on 3D scans. We have also a picture of your genital system, megaclitoris in a female genitalia, hydronephrosis, and here we have a polycystic kidney in the multiplanar display that in the render mode we can see with all the cysts. We can take and isolate this kidney. We can isolate it with an electronic scalpel and use the silhouette mode where we can see not only the surface of the kidney but also the cysts inside. That's examples of the 3D of the spine. Here we have the normal spine. We can have trace a curved line to get the whole spine and the ribs. Here we have an example of open spina bifida, and then we are doing a 3D scan with the silhouette mode. Here we don't have a meningocele that protrudes the back of the baby, but a defect on the skin that we can reproduce on 3D scan. We can see here the defect on baby's back. Extremities can also be assessed. We can not only see the bones, this transparent mode, but also with the surface mode, we can see the surface of the limbs with the polydactyly or talipe. This is an example of a patient. This is a scan at 10 weeks of gestation that we realized the baby had bilateral ectrodactyly on both hands, and then we could do a 3D scan to show this abnormality in three dimensions. Uh, we can also assess the fetal heart, not only the anatomy but also the function. We have here the multiplanar render mode, and then we can use the color and use a TWI. Okay, here we can, I will play it again, because we can see here a ventricular septal defect with blood flows going from one ventricle to the other. We can also assess the placenta, okay, not only the baby, but also structures in pregnancy related to the baby. Here is an example of a patient with a subcentriate placenta, two lobes, one anterior, another posterior, and the cord insertion is just in between, it's in the middle, is the marginal and filamentous cord insertion. So if we do a 3D here, we can see in this same patient the anterior lobe, the posterior lobe, and the cord insertion here. And it's the same picture in another setting, in another display mode. We can also assess the umbilical cord, the insertion in the placenta, just loop of the umbilical cord, and also the knots. It's also useful in multiple gestation, twins, triplets. This is easier to get in early stages and first trimester, because later on one twin will cover probably the other twin, and it's more difficult to get nice 3D and 4D pictures. We can also assess the extent of anomalies. They are not proper fetal abnormalities, but echographic ultrasound markers that we need to assess. Here we have an increased nuchal translucency, shows almost a cystic hygroma here, 5.9 millimeters. In multiplanar display mode, we can see here the increased nuchal axial view and coronal view, this whole hygroma here. And if we do the render view, we can also measure this increased nuchal translucency. As you can see, it's almost the same, 5.8 millimeters. This is, I wanted to mention this part, even it's still under research, because last studies have talked about estimated fetal weight through 3D scans. So it makes sense that the estimation of the weight could not be only assessed by the traditional measurements of BPD, HC, abdominal circumference, and length of the femur. There are some studies that have shown that could be a more accurate estimation of the weight if we also measure the volume of the limbs and the abdominal circumference. So when it comes to early pregnancy and first trimester, I will not say too many things after Peter's presentation, but 3D 4D sonography has moved prenatal diagnosis of fetal anomalies from the second to the first trimester of pregnancy, making the diagnosis of fetal abnormalities early in pregnancy with a great impact in patient care. I'm asking you a question. Images of fetal face in the first trimester, yes or no? So, since we have the machine, we always try to get 3D pictures at any stage, but it seems to be counterproductive to show 3D image of the fetal face to the parents during the first trimester if it's not for medical reasons. For most parents, the image of the fetal face at this stage appears to be strange, and it can create a distorted image of their child. So try to show better a lateral view of the whole body instead of amplifying the screen, trying to zoom the face, because usually they don't like it at these early stages. And a very important question now, is it time for routine use? From 1980, several attempts were made to develop 3D ultrasound systems. Many highly experienced operators were skeptical about the necessity for this new technology, and typical questions were: is 3D ultrasound more useful in prenatal diagnosis than 2D ultrasound? Does it improve diagnostic accuracy, or is it only good for keepsake images? Can we detect more malformation? Is it a useful routine analysis tool in daily practice, or is it more time consuming? Nowadays, more ultrasound equipment have incorporated 3D 4D technology into their scanning system. So, were these questions answered? 3D 4D ultrasound expands the diagnostic possibilities in prenatal diagnosis and provides the operator with additional information compared to the ultrasound. It also offers a detailed demonstration of fetal defect, but at the moment, 2D remains the best way to examine the fetal anatomy. But of course, 3D can be useful addition. The advantages of this 3D and 4D ultrasound are obvious, but the use of this tool is still under close research evaluation in certain areas, such as fetal behavior. Multicentric studies of fetal brain function has been carried out, and the aim of which was to establish the standards of fetal body movements and facial expression as a diagnostic criteria for brain impairment. Also, maternal fetal bonding evidence suggests that 3D ultrasound allows a better recognition of the fetus, which reduces anxiety, stimulates a parental bond, and contributes to positive health behavior. Diagnosis and follow-up of fetal vascular anomalies. Since we saw before that we can isolate a vascular tree that give us a better understanding of both normal and pathologic vascular anatomy, and there are plenty of research on this line. The volumetric measurements of fetal organs. Apart from the studies that I have mentioned before that predicted estimated fetal weight from the fetal volume, there are others like this one of Falcom, of the group of Nicolaides, that reported the volume of fetal head and trunk and documented that triploidy and trisomies 18 and 13 presented early onset severe asymmetrical growth restriction. In contrast, trisomy 21 and Turner syndrome, which are less lethal, the growth restriction is milder and symmetrical, and they could demonstrate that with the volume of the head and the trunk of the embryo in the first trimester. And finally, the 4D ultrasound guidance for invasive obstetrics procedure. It shows a needle tip in 2 or 3 planes, which permits an accurate needle placement, especially when the tissue target is small, as in a CVS or a chordocentesis. So during an invasive procedure, we are going to be able to see the needle from many different planes. So to summarize, 3D and 4D ultrasound offers possibilities not available with 2D ultrasound. Making the diagnosis of fetal anomaly early in pregnancy will have a great impact on patient care. With this new technology, we have increased not only our knowledge about fetal development, but also the impressive images obtained with HD Live offer us the occasion to feel closer to our patients, and we can establish a friendlier professional environment that is useful during monitoring the pregnancy. Acoustic exposure levels during 3D 4D ultrasound examination, as expressed by the thermal index, are comparable to the 2D mode ultrasound due to the fact that most of the diagnostic information is received from stored volumes. The entire acoustic exposure is even less intrusive than in 2D ultrasound. And 3D ultrasound has been shown to be a problem-solving tool in selected circumstances and may well become a part of many obstetric ultrasound examinations in the future. However, it is not yet widely used on a routine basis perinatal medicine. Thank you for your attention.
Thank you very much, Margarita. This was the perfect last talk of this course, just summarizing not only the 3D options that we have, but also the importance of 3D for diagnosis in obstetrics. So Margarita and Peter, if you want to go up for a few questions. Thank you. So I would say we'll keep this a little bit shorter, maybe 10 minutes, and then we can go to lunch. And after lunch, we will have a panel discussion with final remarks, and we can go back to Dr. Stadmauer and Dr. Moliner for further questions. Any questions? Okay, I have a question. So we are very interested in studying yolk sac and the uterine, the vitelline vessels. And so what do you think is the best option, since it is not recommended to use Doppler? And specifically, what about using 3D slow flow? Will that be cause damage, you think, of embryos? Thank you.
So what the technique that you could use is the B-flow. So just try, if you have a nice image in 2D of the fetal duct, to use the B-flow. Because I made some very nice images, but of course I need you to have a more evaluation of this technology. Because I love this B-flow technology because it's not Doppler. It's not color Doppler, but you have a very nice view of the fetal duct. So just try this one. But if you do of course 3D you can do it, but then you only have the anatomical information. So if you want to see the flow, but of course what you already said, a Lara principle, just don't do the Doppler right away in the fetal duct, but try the B-flow to see what kind of images you get. Because I got really nice images of showing the blood flow of the fetal duct. So that works very nicely.
And you
quantification of blood flow, of course, is always with the Doppler. So that's why. So that's really, of course, as a company, I cannot say just do Doppler. Of course, the technique is available, but first I would like to ask you if you can see the blood flow nicely in a 2D way with the B flow.
Okay. Yeah.
And then for the 3D, again, it's anatomical information. So I don't know that it's very nicely to see the image of the fetal duct, but it doesn't give you any blood flow information.
Mm-hmm. Well, Roberta Vitario is the one working on this, and she's been using the grayscale.
Yeah. So you could, for example, I know you could try to get if you would freeze the image, you could try to do an histogram. Because
yes,
you also show the histogram very nicely. So that's also a possibility. Yes. Because I think the use of histogram is a bit underestimated. So it's a very nice technology, because I also wanted to start to use this histogram evaluation, for example, for when you have the more echo-dense bowels, for example. Sometimes because of the high frequencies, but try it also, because I was trying to set up the study with the University in Groningen to have this histogram on the bowels, for example. But also try it in the B-flow.
Yes, we will try
because then at least what I said, so try with this one. But I would not recommend, of course, as a sonographer also to right away use Doppler. Yes.
Anybody wants to ask other questions? Helene?
No worries, you were only talking to Roland, so that's fine.
No, because I'm writing the thing. I think you can do several measures automatically with the machine, and I'm not sure if it's not possible, or really you don't think that is an interesting field, that
if it's possible to measure immediately in a volume um, the endometrial thickness and endometrial volume, you know, because it's easy with the vocal, but no, and probably we have more measures to 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 see more ultrasound markers to see in relation with our outcomes. But I'm not sure if it's an interesting field or if it's very difficult to imply inside the machine.
No, I think what you also mentioned in your presentation of volumes, of course, but for example, a volume of an embryo could be very interesting because it not only measuring a kind of CRL, but also.
And endometrial volume.
Oh, sorry, but then it was a misunderstanding for me because I thought you were talking about the volume of the embryo.
I'm sorry, no.
No, now you're talking about the.
It was impressive, but I don't see embryos. I don't
No,
see
no, I know,
pregnancy.
but I thought maybe, yeah, but.
No, endometrium. I'm talking about endometrium. Sorry. So that's why I'm telling you that could exist. It's possible to develop this kind of pattern, but I want to see the endometrial volume and endometrial thickness automatically. Do you think so? Or because you have implied more things, you know, in obstetrician?
No, yeah, but that's right. But you saw already more a shift to the gynae imaging and the IVF because I think it's very interesting to have this because I think you also did the focal already on the endometrium. I think you were tracing every evening all these volumes. But yeah, I cannot what I said. So of course there's a big interest to continue with this one because also what I said about your study because that's really a focus of also for gynecology. It's not only about obstetric, but it's the whole package. We also because that's also we have Fiona who's really taking care of this market. So maybe it would be interesting to sit with us for lunch. No, I love it. No, we need to do that. That's how a company also gets feedback. Because you will not, you know, you saw the whole Vodafone team. We are also crazy about volumes and ultrasound. So we can speak for the whole day about technology. No, that's fine. No, please ask us.
Yes.
No.
I have a question for Margarita. I loved your talk, of course, but I wanted to ask you whether you see an application in fetal medicine for vocal in terms of placenta, amniotic fluid, and embryo, for example. That was what Dr. Vasquez did in her thesis, in her PhD thesis. What do you think, for example, an application in evaluation of preeclampsia or other?
There are plenty of things that you can do with volumes and vocal and placenta, of course. There are studies now regarding fetal brain differences between babies conceived after spontaneous pregnancy or IVF. So you can also measure the volume of the brain at different stages of the pregnancy. There are plenty of studies regarding volumes, and you just need to assess what's your objective. I think nowadays it's possibly almost everything to do.
Yeah, that's very good. Thank you. If nobody has any questions, I think it's time to move to lunch and come back here. Um, let's see, at what time, Jairo? Maybe 45 minutes lunch, 30 to 40